Hello everybody. My name is Manish Deshmukh. Today I am going to take you through the most advanced active knee replacement robotic system. The system is brought to you by Merrill and Curexo. This is an image based system and has three components. One is the planning station, the second one is a main console, and the third one is the robotic console. Upon admission of the patient to the hospital, we do run a CT scan, which is typically from femoral head to the talus. And in the critical areas of femoral head, the knee region, and the talus region, we do 1 millimeter slice thickness. In between, it could be 5 to 10 millimeter slab thicknesses. The entire CT scan of the patient is archived on a pen drive. This pen drive is then uploaded on the planning station, and a detailed plan of step-by-step surgery execution is then built a evening before the next day morning surgery. The pre-plan would take hardly 20 to 25 minutes on a higher side, and I would like to take you through each of the steps one by one. Please follow me here. Upon uploading the CT data set to the planning station, segmentation is the first step that we need to do in the pre-plan. What it does is actually it separates the bone into cancellous, cortical bone, as well as it can see periosteum separated, as well as the soft tissue bundle, which is also separated out. So it basically sets in the cutting margins on the bone only, and hence the robot will always cut only the bone and not touch the soft tissues. Now, what is achieved by segmentation is what we have the most advanced software feature, which is auto segmentation. And once it is clicked, you get the 3D image of the entire bone that we have scanned. And then of course the axial, coronal and sagittal images are also available, so you can check the images and flip it around and see, take a 360-degree view. And then we go to the step-by-step planning phase. So in the first place, we then define the femoral axis. To define the femoral axis, we need to take the center of the femoral head. We then need to do the condylar center, which is the center of the two femoral condyles. Each time you want to select any point, the image appears as to which is the point to be clicked. Then we do the next one, which is the medial epicondyle. Then we also do the lateral epicondyle. Then we do the medial posterior condyle, and then we also do the lateral posterior condyle. Additionally, we also have to do the medial distal condyle as well as the lateral distal condyle. Post that, what one does is to go implant specific. So from here, it is all a freedom knee surgery. So what it does is it overlays the freedom implant and all the 6 degrees of freedom, which means it comes to flexion extension, it comes to internal external rotation, the varus valgus, all the 6 degrees of freedom is something which we have to fix it up here and see how the implant looks in real time. After matching this, we can again, you can see, you can flip the image around and check if everything is looking good. And there are planning annotations on each of the windows, whereby you can do all sorts of manipulation as to how will the implant sit onto the femoral bone. Post that, we need to define the femur registration to achieve this, and the first step is to check the medial, and then go to the lateral point, and then go to the distal, anterior and posterior points on the femur. That completes the femur registration. Then we go to the next step, which is the TBL axis. So in that, we take the proximal center, then we come to the ankle center, and then of course we identify the tibial tuberosity. We do the PCL femur center, and then we actually come to the medial condyle center followed by the lateral condyle center, and after that we can again overlay the freedom TBL implant onto the femoral bone, and the adjustments again are possible. We can take a 360-degree view, we can rotate the image, flip it whichever way you want, and we can, in the process, we can again check the posterior slope, we can do the internal external rotation of the tibial base plate, we can change the varus valgus of the tibial base plate. And once all these things are done, we are happy with the plan, then we go to the TBL registration, whereby we take a proximal TBL point, then we go to the medial TBL point, then we take the lateral TBL surface, and then we finally take the anterior TBL surface. Once these points are picked up, the TBL registration is over and done. Mind you, in all these point picking, it is an individual slice thickness which is correctly identified typically by yourself as a surgeon, and then we arrive at the summary of the total plan. The summary comes up like this. You can again check your HK axis, the implants perfectly overlaid, femur, tibia, the size of the insert, you get to know all your dimensions, every detail, and the entire plan is available here. Once you see everything is good, that's the time you can click on that approved. Once that click is done, the approved plan is something which you can again have a look see, and you can archive the entire plan on a pen drive. The pen drive is then uploaded on the robotic console. The robotic console will then implement this plan in the surgery next day morning. Once we have done the pre-plan, the images are plugged into this robotic arm. So the surgical plan is imported into the robotic arm. And this is the time where we see the first screen as the system is on. And this is where we are. So the first screen shows like any laptop would boot up. So it checks all the connections, whether the robot is connected, the pendant, which is actually the remote control, which will be in the surgeon's hand to control and maneuver the procedure, and then the optical tracking camera, which is the eye of the system, which is going to see the trackers, etc. That is something which is connected, and the surgical plan, as I said, the moment we plug it, it will be imported. So this is what we have planned. I confirm the plan and go to the next step. Now this is the non-sterile diagnostics, wherein we can measure most of the things. It is processing, it will get the robot to a position where we can go to the next step. So what I have done is I have fixed the robotic tool marker. This is a non-sterile thing. Just excuse us because we have draped this robot beforehand, and so this will be in an undraped situation before even the surgeon is in or the patient is in. So with this marker we can do the robotic verification. So all it does is it will make movements in different planes and see if the tracker of this robot is visible to the camera. Now here is the time where one can position the camera so that the red ball which you can see is almost bang in the center, and once this is achieved, we are all set to go to the next step. And as you can see, the calibration is something which is in process, and the robot is going to move through the entire 360-degree range of motion, whatever it needs to perform while it is going to go in the cutting mode. So before that, the calibration is an very essential step. And as you can see, the movement of the arm is just continuously moving, making sure the calibration is perfect and that it works. So as you can see, the verification is almost done, the calibration is done, the verification process is on. Once again, it will make all movements in various planes. Also, at this point, this is a check where, because the movement of this robotic arm is all controlled by servo motors, and various servo motors are working at this stage to make sure things are in place. And this just takes a few minutes. So if I were to actually find out how much time does it take, maybe a minute or two, not more than that. However, as I said earlier, this is all unsterile. This all can be done before the surgeon comes in. The patient anesthesia is in progress. That's the time this whole thing can be done. And I guess this is it. So the verification is done. It is going to tell us if it is successfully done. And this is again, you can see the robot comes in a very friendly position wherein I can easily hold this and pull this out and push this completely out and then easily pull it out. So this is the process in which the unsterile registration is done. Now this is fully calibrated, and you can see the robot is ready to roll. So to begin with, as you can see, this one tells me that there is a probe which I need to do, and it is verifying, and the probe diagnosis is done, it is verified. The advantage of this system is that I can hold the entire tray in front of the robotic sensing, or I would say the infrared sensing camera, and you can see quickly the ticks have come on all the tools, the femur, the tibia, the robot, the restoration marker, everything. So in one go, this is done. Generally, there are other systems where each and everything has to be verified one after the other and takes longer. But as I said, this is a smart chap in your theater, and a smart robot does a smarter job. And this is actually the time, where you would again position the robot and do the entire draping, which I have already done it. Again, this is the time where it is asking me to install the tool, and for that the robot is again going to come back to me in the most convenient position where I can actually hold the assembly. So all I do is I connect this cutting tool and the motor assembly. So during the surgery, the cutting tool will be fixed here, and the computer needs to know where exactly the cutting tool is going to cut the bone. And hence you can see that the sterile cutting marker is already mounted up here at the tip of this cutting tool, where the cutting tool will come. This is actually the motor which is going to be doing the cutting job. And here I'm trying to show you something which is called as a restoration marker, where the marker can be fixed on the robotic arm to be able to see what is the position. So now I have fixed the restoration marker on this, and this is something which has to be done to check the position of the robot each and every time. So in case there is any movement in and around, the restoration marker is something which is very handy through the process. And if we can go to the next step now, I can show you what comes up next. So you can see that it is verifying the cutting tip, and then we go to the next step where we again pose clear, and each time you can see that the window comes up to confirm, so that you are very sure about what you are doing. And you can see it once again, the robot marker must be stabilized, so you need to confirm. The robot will operate and check the foot brakes. So the robotic check marker is being checked again, and as you can see, it is again going to move through the same range of motion and verify everything is all right, almost same as what it did in the unsterile position or unsterile condition. Everything in sterile condition is also something which it checks. So you can see that the FT sensor is getting calibrated. And after that, this is the time where we need to put the cutting tool in place and to install once again the robot in a sterile position will be coming straight back in a very easy position where one can hold the robotic tool in place very easily. And as I can show you that this is how easy it is. With this, the entire assembly is out, and then I can show you the tool which is pushed in here. So once the tool is in here, all you need to do is one half a turn and the tool is fixed. You can see that the tool is completely fixed in place. And there we can go to the next step. Each time it is going to ask you the confirm window, where it will be telling you to confirm the thing, and hence it just processes. Now it is processing the cutting motor. I'm sure you would have been able to hear the motor sound. So the motor was just starting motor and irrigation verification. Right now, I must confess, yes, we are yet to put this irrigation tubing out here, but it is just on a small clip, and there is continuous irrigation which will happen at the tool during the cutting process. So once this is verified, this is, as you can see, this was all a sterile process, and now is the place where we move on to registration. So as you saw that all these things could be done by the technician or the surgeon's assistant before the surgeon is in the theater. At this stage, I would like to show you that the computer is absolutely on an autopilot mode. It tells you that the robot is now ready, everything is done, you are in good shape, and this is the time that you need to do the registration, as you can see on the screen. So at this stage, an incision is taken. Whatever incision is fine, whether it is medial parapatellar or your MI incision, if at all those incision types are acceptable to the system. There is no limitation on that. And then again, typically with a 4 or 5 finger down, you can just fix the TBL pin on the TBL shin. The position is this. It's almost like a 45 degrees angle, and what we do is this pin is bicortical, which actually means you cut through the first cortex, but then you go and just hit the second cortex. You don't need to pierce it, of course, as you can imagine. And I'm going to just show you how this pin is fixed, and then you are ready to move to the consequent pins. So to put the marker, we have this particular device which actually gives you a distance of calibration where to put the next pin. So 2 pins on tibia and 2 pins on femur, and this is what I'm just going to show you already. So as you can see, I've just fixed the TBL marker, and I'm just going to show you how I get my femur marker in as well. And you can notice that it is very quick and fast, doesn't take more than a minute. You can see that these reflective markers are very well protected, so that in real surgery the blood and the saline water doesn't spill on it, and they don't blank out. So that's very intelligent step. Now once the markers are in place, it is the time to see if the camera can catch both the femur as well as the tibia. So as I just got got this too. I have got both the TBL as well as the femoral markers in place. They need to be very tight because your femur bone is going to be considered with respect to this tracker, and your TBL bone will always be considered with respect to the TBL tracker. As simple and same as what the navigation process is. Pretty much a very simple registration, as you can imagine, and there is a screen which guides you every time. So I'm going to take medial point. So this is the step of femur registration. As you can see, medial epicondyle, I'm there. Then it straight away tells you to go to the lateral epicondyle. This is what I have done. Then you can come back, and it is a distal registration point, and this is it. And then you can go to the anterior registration point. The position of the point is exactly shown by the computer, and you can actually come back and see the points. So on the femur, as you can see, I need to pick up something like 15 points. Okay, 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 almost on the lateral side. Okay, 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 this is it. Now you got to go on the posterior lateral. So I am supposed to collect some points here. And now posterior medial points, starting from the groove going inferior again. So now are the points which we take on the medial ridge of the femur, and I go from top to bottom. Same thing I'm going to do now. Okay, I'm going to register the anterior portion of the femur. So I go more distal, and from distal to proximal is how the sequence is. And then I move to the lateral ridge, going distal, and going distal. So 10 points picked up. The registration is successful. You can find the RMSE is 0.79, and the final RMSE is 1.87, which is a good thing to do. And so this is like a femur medial registration point. So I go here, and this is something which I should be able to go back to the point whenever I have some movement. If there is a relative movement, I should be able to go back to this point. So when I pick up this point, maybe I can mark it with the cautery there, or put some bony dent and make sure that point is again reachable. Same thing about the lateral registration point. So these 2 points are quite fixed, rigid points, if I were to say. So here we are at the next step. We've done the registration of the femur completely, wherein, as you saw, all the points on femur have been taken. So here is the place where I'm moving on to the TBL registration. So this is the proximal TBL point where I am taking this. This is it. It's done. The medial TBL point. This is it. I'm done. Lateral TBL point. This is it. I'm done. And the anterior point, which is right on the TBL tuberosity. Once the points are done, then I move wherein I need to sometimes subluxate my tibia a little forward to be able to reach all the points. This actually comes from posterior to anterior. So this is the first one, this is the second one, this is the third one, this is the fourth one, this is the fifth one. Likewise, I continue taking various points. There we do some points on the medial side. There we go. And then on the anterior surface of the tibia, medial, then move towards lateral, then again little lateral, and then again quite lateral, then I come little posterior, then go towards medial, then go again towards medial, then come again little posterior. Yeah, here you go. So the TBL registration process is complete, and then I just take another point which is medial, and then another point as lateral, this completes the femur and the tibia registration. In actual surgery, in surgeon's hand, it would take about 5 minutes for sure. Once the femur and the TBL registration is complete, the next step is to do a pre-gap check. So I'm trying to see what is the position of my pre-gaps at almost full extension, and as you can see, this is what it stores in terms of a plan, and I'm trying to make it as straight as possible, but there seems to be some kind of a FFD and then some varus as usual. So this is it, and you can see that the medial tightness is seen at 90 degrees, the flexion, also the gaps are stored. So this is what it gives me, a rough visualization of my joint, as in what are the pre-gaps before even making any cuts. We go to the next step, and here is a time where we need to select either of the measured resection and modified gap resection. So which is the one that you would prefer? I mean, the way to look at this is, you may want to go for a measured resection and say that I as a surgeon is going to balance my soft tissues. The other way to look at it is, if I can assess the pre-gaps after doing the proximal tibia and the distal femur, and then do the balancing of the gaps in flexion, that's basis some cuts which I decide, my rotation I decide with respect to either epicondylar axis or posterior condylar axis or a TBL cut. I have a choice to do that. So it's purely surgeon's choice whether he wants to choose a measured resection or a modified resection. Right now, for demonstration purpose, it is easy to straight away show you a measured resection. So as you can see, the robot positioning is something which needs to be done at this stage. So we've done the robot positioning, and we've got those two circles which you see on the screen, front view and the top view, which are blue in color, which actually tells us that everything is visible, nice and clear. What I've just done is I've inserted two screws from the lateral side, and with the rod and assembly and these Hoffman screws, this has been completely tightened, so that I have also done a little bit of retraction of the knee joint, so that when my cutter comes to do the cuts, especially on the posterior side, there is enough space on the femur as well as the tibia to work through. And next to we go to the next step. As a next step, the robot has automatically applied the hydraulic lock, and the robot is now rock steady. With this, there is actually no movement relative between the robot and the joint, the knee joint. And hence, with the registration, the robot knows where in the 3D space is your femur and tibia, how much to cut as per our pre-plan. Everything is on as a information with the robot. So here we go to the actual resection, and this is the time where it gives you an option whether you want to do a femur first or a tibia first. So I would go a femur first and go to the femur cutting process. It again gives me various options, as in it would take distal, anterior chamfer, anterior, posterior chamfer, posterior box cut, all that. Now before we move for the cutting process, what I want is, because you saw that we've changed the position of the robot and then locked it in a place, we want to do restoration. So this position is something which is known to the robot all the time. The brakes are applied, the robot is rock steady with the hydraulic lock, but this is a step where the restoration marker is also being seen by the camera, and this position is something which will be remembered, recognized by the system once and for all. So for example, if there is some movement, now you can see in the meantime the restoration has been achieved and the robot is ready to operate. I was trying to tell you, if there is some relative movement between the knee and the robot, all you need to do is do the restoration, because then with this the positioning and the relationship between each other is very, very clear once and for all. So here we go with the cutting sequence, and we do the distal femur first. As you can see, the robotic arm is now moving in the real space, and it is coming close to take the distal femoral cut. On the screen you are able to see that it is defining the cutting plane, and it starts making the cut. This being the sawbone, there will be some dust which you can see flying, but in the real time operation room scenario you will not have dust flying around. And also there is a irrigation which happens. So with the irrigation, continuous irrigation, there is no risk of any bone necrosis. Having said that, on the screen at the bottom, right bottom, you can see that there is one bar which is advancing continuously. You can see that this is called as a bone movement monitoring. In case there is any relative movement between the robotic arm and the knee joint, the arm is just going to stop cutting. The maximum limit is 0 to 3. If it exceeds, then the cutting operation quickly stops. And the response time to stop is just 0.01 second. As you can see, the distal femur is completely resected. So the distal femur cut is done. And as you all can see on the computer screen, the next cut is your anterior chamfer, and right now the cutting tool is approaching the anterior chamfer cut. On the left bottom of the screen you can see the speed right now is 35, 40, 45, and then when you reduce it, you can reduce it. The maximum is 50. You cannot go beyond that. The cutting tool, you can see, is cutting really, really fast, and then you just got to go slow. So this is also a safety feature wherein, you know, you as a surgeon, you have a way to control the speed, increase or decrease the speed. Here the robot is actually getting into doing the anterior cut, and you can see on the screen how the anterior cut is going to be taken, and that's what it is doing right now. It does a proper grand piano sign. As you can see, it is now going to do the posterior chamfer cut. Now it is going to do the posterior cut. It makes the lug holes as well, as you can see. And finally it does the box cut. So after the box cut, it took the trochlear cut, and that is the end of all the cutting. All the resections on the femur are completely done. Then we move to the TBL cut, and I would like to point out that you can see how the TBL cutting happens as the cutting tool advances from medial to the lateral side. Here you go once again. not to wonder what was really the magic tool in my hand, this is what I was using. And as you can see, this will be given in a sterile pouch, and it just has got a enter button, up and down key to increase or decrease the speed, or even to change the menus on the screen if need be. And there's a pause button, and here right is the emergency stop button. In case you see that something is not going right and you want to quickly stop, you can always do that. So as you can see, we are ready to do the keel wing, and at the press of a switch, on the remote, I just say start. This is it. It asks me to confirm again. Moment I confirm, the cutting action will start. The robot is back in action. As you can appreciate that in real time, how the tool is advancing within the tibia to make the keel whole, and now is the time it is going to create the keel wing after creating a circular hole. So right now the keel wing preparation of the keel is in progress, and after that it will also create the wings, and this all happens as per the rotation that we have set pre-operatively. So as you all saw, all the cuts are completed now finally. The beauty of this is the cylindrical cutter can do the peg holes, the box cut, as well as the keel, and create the keel wings as well, which not a single system is capable of doing it today. Now in case, after I am ready to put my trials in, and in case I feel that I want to add the cut, you can see that there is an add cut provision. So all of that is possible. So this is the time after all the cuts I have been able to put my trial implants in, and this is a real time, the check of the truth. The moment of truth is out here, and you can see in flexion the medial and the lateral gaps are almost equal, 17 and 18 millimeters. This is at about 97 degrees of flexion. I'm going to try and make it full extension. How much does it achieve? And I have been able to almost straighten it out and see. Yeah, so you can see that it's an equal balanced gap of 21 millimeters on medial as well as the lateral side, and almost full extension. There is a zero varus valgus that you can see, and again if I try to flex it and bring it at about 90 degrees, this is where it stands, and you can see that it's about 16 millimeters. Obviously on a sawbone there is a limited thing that you can show, but I think this was a moment of truth where you get like equal gaps on both the sides, and you can as well of course check what's the kind of maximum flexion on table that is possible, and I think well, we can say about 143 is quite a good job done, no impingement, etc. So all the checks can be done at this stage, and that's about it. So on the final screen, once you have your trials in, you can actually verify everything. It gives you the operating time and the moment of truth where you can actually verify what was the pre-op alignment versus what is the post-op result. And post this, of course, you can remove the components, the trial components, and cement the final implants. Thank you very much for being with me. Thank you for your patience. Appreciate your time. Thank you very much.